Very good morning. We welcome you to this session of Cuddles online neonatology education program. And today we're going to discuss about one of the most common morbidities that we see in preterm neonates, bronchopulmonary dysplasia. This was first described in 1967 by someone called Northway, who described the classical form of BPD or old BPD as we know it in 4 stages, mainly radiological staging. Most of these babies at that time who were developing BPD were late preterm. They were relatively big babies, mature babies who had received prolonged duration of invasive ventilation. And these babies used to have the more severe variety of bronchopulmonary dysplasia requiring prolonged ventilation, high concentrations of oxygen, which has now become more and more uncommon. Although a milder form of BPD, which is often referred to as new BPD, which is somewhat akin to stage 2 of the older classification of BPD radiologically, is being more and more seen with increasing use of modes of non-invasive ventilation such as CPAP and early rescue surfactant therapy. So this is a slide which shows that in all birth weight categories, starting from babies born between 500 to 750 grams, to across the diagram to the babies between 1251 to 1500 grams on the right extreme, in all groups of babies, the survival has become better. In other words, the percentage of babies who die because of prematurity, represented by the dark gray colored bars, is becoming lesser and lesser with increasing years. But what we are seeing is, particularly in babies who are born less than 1000 grams, this improvement in survival is also indirectly leading to an increase in survival with BPD. So more and more babies are today surviving with bronchopulmonary dysplasia when compared to 10 years back. So this is a study done from the All India Institute of Medical Sciences, Delhi, as a part of the MD thesis, which kind of tried to evaluate the incidence of different categories of BPD, mild, moderate, and severe in different gestational age groups. So overall, when all babies less than 32 weeks were pooled together, the incidence of BPD was nearly 33.9%, so which was almost a third of babies less than 32 weeks. But as expected, the incidence of BPD in the lower gestational ages, like 24 weeks, 25 to 26 weeks, was close to 100%. So less than 26 weeks, there was almost always a definite chance that surviving preterm babies may go on to develop bronchopulmonary dysplasia, and the incidence kept coming lower and lower with increasing gestational ages. Now, in order to understand the various strategies to prevent or treat BPD, let us try and understand the pathogenesis of BPD. Now, BPD is a developmental lung disease which is characterized, which evolves on the background of genetic susceptibility, on the background of premature delivery when the baby's lung is still developing, over and above which multiple postnatal exposures and risk factors kind of superimpose in order to culminate in the fully evolved form of bronchopulmonary dysplasia the way we see it. So, for example, if you're dealing with a baby who is born at, say, 25 weeks of gestational age, then this baby is in between the canalicular and saccular stages of lung development, wherein there would be ongoing ramification and branching of the alveoli as well as branching of the pulmonary vascular tree. Over and above this, when the baby is exposed to postnatal ventilator-induced lung injury, oxidative stress or oxytrauma, infections-related stress, with or without the effect of postnatal steroid therapy, fluid overload, and nutritional deficits, the baby may eventually go on to develop some grade of BPD based on the extent of these risk factors. So more premature the baby and more severe the postnatal exposure, more likely severe the bronchopulmonary dysplasia. The effect of antenatal exposure, such as antenatal steroids on the effect of BPD, has been controversial. Most studies have not shown significant difference in the incidence of BPD with antenatal steroids, possibly because steroids may eventually increase the survival, and although it has a lot of favorable positive effects on the respiratory distress syndrome component, eventually the net effect on BPD may not be appreciable because of the improvement in survival, which may eventually lead to more and more babies predisposed to BPD. Likewise, babies born through ongoing chorioamnionitis or prolonged premature rupture of membranes may be exposed to in utero inflammation and hence may be at high risk of BPD. This is another flow chart which also represents the various risk factors. So on the background of a preterm baby who has respiratory distress and who requires artificial positive pressure ventilation, either in the form of invasive ventilation and more and more commonly these days on non-invasive ventilatory modalities like CPAP or NIMV, when the baby is exposed to barotrauma due to pressure, volutrauma because of tidal volume, oxygen toxicity because of the fractional inspired oxygen concentration, postnatal infections and inflammation and the cytokine storm, as well as changes in the pulmonary blood flow and lung edema due to hemodynamically significant duct as well as hydrogenic fluid excess. The baby may develop acute lung injury with inflammatory response syndrome, which is characterized by multiple components, including interstitial damage, pulmonary vascular injury, as well as airway damage. So these are three integral components in the pathogenesis of BPD. Airway damage being modulated by the squamous metaplasia from what needs to be columnar epithelium in the lungs. Vascular injury usually caused by the cytokine storm leading to smooth muscle hypertrophy as well as spasm and eventually decreased pulmonary blood flow. Interstitial damage because of fibrosis due to increase in the levels of fibronectin and elastasis, eventually leading to decreased alveolar septation, fibrosis, decreased number of alveolar capillary junctions or alveolar capillary interfaces, leading to less effective gas exchange, pulmonary edema, hypertension, and airway obstruction and atelectasis. So this is a histological picture, which might be a little kind of light on the the video. So this shows the changes that we see in the classical form of BPD as well as the newer forms of BPD. So just to remember briefly, the new form of BPD is characterized primarily by hypoalveolarization or decreased number of alveolar septation, which compromises the gas exchange, whereas old form of BPD is predominantly characterized by fibrosis and scarring. Early on from 2001, attempts from the NICHT group led by Alan Job and group have been trying to classify BPD into mild, moderate, and severe. So effectively, if a baby is categorizing for BPD, which is defined as prolonged treatment or prolonged requirement for oxygen more than 21% concentration for at least 28 days, the baby further gets categorized either as mild or moderate or severe BPD based on the oxygen requirement at 36 weeks of post-menstrual age. Mild BPD, wherein the baby may be breathing room air, moderate BPD when the oxygen requirement is below 30%, and severe BPD when oxygen requirement is beyond 30% or if the baby required positive pressure ventilation. And this was the older classification. Now in 2018, this classification has been modified and it looks something like this. So here, any premature baby less than 32 weeks of gestational age with persistent parenchymal lung disease, along with the radiographic confirmation of parenchymal lung disease, characterized by parenchymal opacities, when the baby reaches 36 weeks of PMA and requires one of the following FiO2 ranges or oxygen levels for at least 3 consecutive days to maintain saturations between 90 to 95%, which are defined as the target saturation levels, is then classified into the grade of BPD accordingly. So if the baby were on invasive ventilation at 36 weeks of PMA, then the baby will either grow into grade 2 or grade 3 if the baby required room air or anything more than 21% respectively. On the other hand, if the baby is only on low flow nasal cannula oxygen below 1 liter per minute, the FiO2 requirement of the baby determines the grading of BPD, wherein anything between 22 to 70% would become grade 1 and anything more than 70% becomes grade 2. Importantly, a baby who had early death between 14 days of postnatal age and 36 weeks of age, owing to persistent parenchymal lung disease and respiratory failure that could not be explained by any of the other neonatal morbidities like NEC or IVH or sepsis, is also categorized into BPD 3A because some of these babies would have possibly survived had it not been for BPD. So these babies may not survive until the classification time window of 36 weeks of PMA. But these babies have also been included under the classification in under grade 3 BPD 3A. So clinically, how do we identify that a baby is evolving to develop BPD? So typically a baby with RDS who has started to improve or after improvement has started to again deteriorate after an apparent improvement is suspected to have BPD, or worsening oxygen requirement into the second week, which again may culminate in the definition of BPD, or if the baby has the typical radiological parenchymal appearance of BPD along with any of these above clinical signs, again, we start thinking that this baby might be developing BPD. Now, it must be remembered that sometimes the radiological features changes may lag behind the clinical features. So if you have an extremely premature baby, say, who is born at 24 weeks, and who apparently improved and came out of maybe ventilator with surfactant and was doing well until say day 10, day 12, and then starts deteriorating with increasing FiO2 requirement, increasing requirement for pressure, and possibly required reintubation. And if you have ruled out other potential causes like a large PDA, infection, or pulmonary air leaks, or atelectasis, and other ventilator-related misadventures, then we could be potentially dealing with BPD, and the subsequent X-rays may start showing the changes of BPD. So coming now to the radiological classification of BPD, this was exactly what was proposed initially by Nordway much early in 1967. So stage 1 BPD is usually radiologically similar to RDS or hyaline membrane disease. So it's characterized by bilateral ground glass opacities, whiteout lung, or presence of air bronchograms. Stage 2 BPD, which develops later on in the first week, is characterized by non-resolution of HMD or presence of persistent atelectasis. So if you expect RDS to have improved, but the baby still continues to have bilateral hazy picture of both lungs, then this could be an indicator of stage 2 BPD. Now, stage 3 is when the baby starts developing more advanced changes like the presence of translucent cysts or emphysematous changes interspersed with linear streaks. And in stage 4, all the changes we see in stage 3 become more severe. So these two X-rays we can appreciate are indicative of significant cystic hyperlucencies in both the lungs, and this is interspersed on a background of parenchymal opacities characterized by fibrosis. New BPD, what we see more and more in today's era of non-invasive ventilation and early rescue surfactant and the principles of reducing ventilator-induced lung injury, babies still go on to develop BPD, and these babies tend to have changes which are described as new BPD, which look somewhat similar to the stage 2 classification, radiological classification, wherein there would be just persistent bilateral haziness. We may not see much hyperinflation, fibrosis, or emphysematous bullae. So let's now talk about how to prevent BPD. Having discussed so much about its pathogenesis, about its classification, and about its clinical and radiological features, we shall now discuss about prevention, because particularly with BPD and more so, and also with most of the other neonatal morbidities, prevention is always better than cure. Now, the prevention of BPD or lung protection, which are both interchangeably used, starts from the antenatal period, beginning with a complete course of antenatal steroids in the form of 2 doses of betnosol or betamethasone, given 12 milligrams 24 hours apart, or 4 doses of dexamethasone. So either of these can be used, and once the mother has completed at least 24 hours from the last dose, we consider this to be a complete course of antenatal steroids. Likewise, we discussed how chorioamnionitis is a predisposing factor for ongoing inflammation in BPD, and hence the appropriate choice of intrapartum antibiotics for PPROM, which has been debated a lot, and as per the Oracle group of studies, seems to be oral erythromycin, which seems to target most of the non-gonococcal urethritis causing bugs, seems to be a good choice in this group. These two are useful strategies for prevention of lung damage as well. Delivery room interventions, there are quite a few, including cord management in the form of delayed cord clamping, or umbilical milking in babies more than 29 weeks of gestational age, Avoidance of use of high pressure and large volumes. So avoiding the use of a large bag or using high pressures, preferably using a T-piece resuscitator for providing positive pressure ventilation. Use of sustained inflations has been debated a lot, but the SAIL trial has actually refuted its role in lung protection, and rather it has shown a trend towards increase in mortality. And the use of blender air oxygen mix using a blender guided by pulse oximeter to target the saturations, minute-specific saturations in preterm babies as well. All these are useful delivery room strategies for lung protection. Once the baby reaches the NICU, there is a whole list of lung protective strategies, some ventilatory management, some non-ventilatory nutritional management, and some pharmacological management strategies, starting from early CPAP for babies having significant respiratory distress, and a careful choice for early rescue surfactant. These days, we are talking more and more about minimally invasive surfactant, LISA or MIST techniques. And if the baby requires ventilation by any chance, then the ventilator strategy must be titrated to make sure it is a gentle ventilator strategy, which includes the use of fast ventilatory rates, short I times, and trying to use optimal PEEP. Using volume-targeted ventilation wherever feasible, and the use of permissive hypercapnia, oxygen saturation targeting, doing early extubation to CPAP, and using caffeine if the birth weight is less than 1250 grams. These are all some useful strategies along with fluid restriction and aggressive nutrition. So let's talk about these strategies a little bit in detail. Now, antenatal steroids is one of the silver bullets in neonatology, one of the age-old, time-tested neuroprotective mechanisms, lung protective mechanisms as well. So every mother at risk of imminent preterm delivery between 24 to 34 weeks must receive a complete course of steroids, either betamethasone or dexamethasone. Giving a complete course of steroids ensures a reduction in respiratory distress syndrome by 34%, including moderate to severe forms, intraventricular hemorrhage by 46%, including severe grades of IVH grade 3 and grade 4 to a more significant extent, necrotizing enterocolitis by 54%, and all-cause related death by 31%. There is also a significant reduction in early onset sepsis by 44%. And although there is no direct reduction in bronchopulmonary dysplasia, reduction in all these morbidities effectively results in lung protection, and this reduction in BPD may not have surfaced because of a potential increase in mortality in those babies who may have otherwise died without antenatal steroids. Delivery room interventions, delayed cord clamping has been shown to prevent anemia of prematurity, reduce the need for transfusions, again reduce the risk of IVH, and improve the baby's hemodynamic stability, leading to a reduction in requirement for inotropes. Likewise, delivery room CPAP has been found to be a useful strategy. While one systematic review did show a trend towards reduction in BPD, some other large RCTs, such as the COIN trial in Australia, did not actually show a significant reduction in BPD, but the early use of CPAP was definitely associated with a 50% reduction in the need for surfactant and mechanical ventilation. Now, as we discussed, sustained inflations, which involve giving high-pressure breaths for prolonged inflation times, were earlier believed to increase the baby's functional residual capacity, but the large SAIL trial did not actually substantiate this benefit and rather showed that there could be an increased risk of mortality, probably because of barotrauma and volutrauma, and hence this intervention is no longer recommended. The use of a blender in the delivery room to blend air and oxygen mixture to deliver an FiO2 of 21 to 30% during resuscitation is also found to be an important measure to reduce oxygen toxicity. Delayed cord clamping, delaying the cord clamping by at least 60 seconds as per the World Health Organization, or for at least 30 seconds as per the ILCOR NRP recommendation, has been found to be associated with numerous benefits, although may not directly culminate into a reduction in BPD, but this, in view of most of the other benefits, this is still a very useful intervention. So every delivery room catering to a preterm baby less than 35 weeks, less than 34 weeks, must definitely have these two important resources, a pulse oximeter for measuring the pre-ductal saturations, and an air oxygen blender, which is connectable not only to the oxygen source, but an air source, a compressed air source, which is definitely essential in the labor rooms if we have to use a blender. So we discussed that sustained inflations are not so useful. However, delivery room CPAP is something that is quite preferable and possible with the advent of TP's resuscitators. So CPAP is something which is good when started as early as possible. The earlier we start for a baby with respiratory distress, the better it is. However, CPAP cannot be delivered with a self-inflating bag or an ambu bag, and hence it definitely requires either a TP's resuscitator, which most of the units these days have a handheld TP's resuscitator that can be carried easily, or a flow inflating bag. One of these is necessary for delivering PEEP. Now, when we come to the NICU, there are a lot of ventilatory strategies that have been time tested, have been repeatedly shown by evidence to help in lung protection. Now, one of the most useful strategies is the avoidance of endotracheal intubation and invasive ventilation, as was seen from data comparing different units across the United States. When the incidence of BPD were compared, it was found that the unit which had the highest utility or usage of bubble CPAP was the unit which had the lowest incidence of BPD. So early CPAP, especially when combined with early rescue surfactant in those babies who selectively require surfactant, is found to be a very useful strategy to decrease the incidence of bronchopulmonary dysplasia. So why is early CPAP so popular now? It is because of some of these landmark studies, which may be very useful for those fellows and DM, DRNB students who are training exclusively in neonatology. So COIN and support trial particularly were the two first trials that included babies born less than 28 weeks. The COIN and support varied in the gestational age criteria for inclusion by around 1 week. Both of them compared early use of CPAP and avoidance of intubation ventilation. The comparison group in COIN was the use of mechanical ventilation and surfactant in those babies who had higher FiO2 requirement, whereas in the support trial, babies were both mechanically ventilated and given surfactant as well. Although the combined incidence of death or BPD was not perhaps statistically significantly different, we can see that there was a trend towards lesser BPD and death in the CPAP group versus the control group, which employed routine endotracheal intubation with or without surfactant administration. So there was certainly no increase in death or BPD with the strategy of using early CPAP and avoidance of mechanical ventilation with or without avoidance of surfactant, even in extremely preterm babies. And this strong conviction came to us from these two landmark trials. Subsequent trials, including the CurePAP trial, tried to see whether CPAP alone could be effective or CPAP was more effective when intubation, surfactant, and extubation as a strategy was added to CPAP. Although in the CurePAP trial, it did not make a significant difference when surfactant was added to CPAP. We all know that there is a proportion of babies who would eventually develop CPAP failure, which is identifiable by various techniques and would benefit from selective surfactant administration. So early CPAP with subsequent selective surfactant administration is feasible in extremely preterm infants, and it also results in lower rates of BPD with death when compared to the standard treatment of intubation along with prophylactic or early surfactant. So now early CPAP initiation seems to be the key, and we did this quality improvement initiative wherein we tried to reduce the time required for initiation of CPAP after a decision has been taken to start CPAP. Very often, we find that once we have decided to start CPAP, we still end up losing some time in trying to identify the right size of cap, the right nasal CPAP interface, connecting the circuit, and finding the other accessories like the CPAP nasal tubing with correct size foam, etc. It may also take some time for finding appropriate skin protective adhesives while fixing the CPAP interface. And hence, we designed a CPAP movable trolley in which all these items could be placed and could be readily moved into the baby's bedside. And this simple change resulted in a significant reduction in the average time to initiate CPAP from around 16 minutes to nearly around 8 minutes by the time the study was completed. Now, not only starting early CPAP, but adding early rescue surfactant in those babies who have CPAP failure criteria is also something that has been found to reduce the risk of BPD. Now, there are various ways of identifying which baby requires surfactant, either the conventional, the FiO2 requirement or PEEP requirement clinical criteria, radiological signs of RDS, or more recently, signs on lung ultrasound. So we kind of follow this protocol. If this is a baby who is born below 28 weeks, then we would consider prophylactic surfactant straight away if the baby's gestational age was below 26 weeks, that is below equal to 25 weeks, or if the baby was born between 26 to 28 weeks with prolonged need for positive pressure ventilation, need for delivery room intubation, or who had received incomplete antenatal steroids. In these cases, we would prophylactically give surfactant, which is within the first 15 minutes. Whereas if the baby did not satisfy the criteria for prophylactic surfactant, the baby would be started on CPAP for respiratory distress and would be given surfactant on an individual basis if the baby required PEEP more than 5 with FiO2 more than 30%. And in both these cases, the baby could be extubated after insure on an individual basis if the baby had good respiratory efforts. Getting a blood gas or a chest X-ray is not required for the decision-making for surfactant administration or for extubation. In babies more than 28 weeks, there is absolutely no role for prophylactic surfactant. In fact, more and more in babies more than 26 weeks also, there is no role for prophylactic surfactant. These babies would be begun on early CPAP for distress, or if in case they required mechanical ventilation, the baby would be given a dose of surfactant if the baby's FiO2 requirement was increasing with or without radiological signs of RDS. Now, an X-ray evidence of RDS is not really mandated, especially if getting an X-ray is getting delayed, but it might be good to document the X-ray findings before we go ahead with surfactant therapy. Now, not only is administering surfactant becoming more and more evidence-based, but the mode of surfactant administration is also becoming lesser and lesser invasive. So administration of surfactant via a thin catheter, which is hardly of 1 French outer diameter, in comparison to the endotracheal tube, avoiding positive pressure ventilation seems to be a promising modality of a surfactant administration. So in this context, a network meta-analysis looked at various interventions to reduce the incidence of BPD, and they found that the top ranking intervention to reduce BPD was LISA, or less invasive surfactant therapy. Now, what is LISA? LISA is a technique wherein one uses a nasogastric tube without the help of a Magel's forceps placed into the larynx under direct laryngoscopic vision for administration of surfactant. And this is holding a lot of promise in the management of respiratory distress syndrome. Now, in a baby who ends up requiring mechanical ventilation, the use of patient-triggered modes wherein one synchronizes the mechanical ventilator breaths with patient efforts, although promising, did not result in decrease in BPD based on the systematic review of randomized controlled trials. But in the interest of patient synchrony and better patient comfort, we must try and use PTV modes wherever it is feasible. Now, while we are either ventilating the baby or managing the baby on bubble CPAP, it is important to accept slightly raised carbon dioxide levels or practice permissive hypercapnia, wherein we accept PaCO2 levels of up to 45 to 50 millimeters of mercury, or even up to 55 to 60 millimeters of mercury in the second week, provided the baby is hemodynamically stable with pH more than 7.25. Now, while one is kind of using respiratory support, it is important to operate in that region in the baby's respiratory mechanics, wherein we have opened up the baby's lungs at functional residual capacity, which is possible by using a relatively high PEEP and by using the least possible tidal volumes required for just managing to bring the carbon dioxide levels to the acceptable range. So we try to use the strategy which involves using relatively high PEEP and normal tidal volumes and not high tidal volumes. So when it comes to permissive hypoxia, the Neoprom meta-analysis has shown that targeting saturations between 90 to 95% was associated with the least kind of risk of mortality without increasing the chances of bronchopulmonary dysplasia. Although there was a small increase in the risk of ROP, this was something that could be managed with treatment. Also in babies who require ventilation, wherever feasible, wherever we have a flow sensor that is available and measurement of tidal volume is feasible, it is always preferable to target tidal volumes using volume targeted ventilation added to pressure controlled modes of ventilation. So we can see these two graphs here. The first graph represents a baby who is on pressure limited ventilation, wherein whenever the compliance of the baby changes with the same pressure, we get drastically different tidal volumes. Whereas when we use volume controlled ventilation, the baby's tidal volume per ventilator breath remains constant. Although the compliance of the baby changes, automatically the peak pressure is weaned off in what we call as auto weaning in order to maintain stable tidal volume. This has been found to be an advantageous strategy because it has been realized that volume trauma is more damaging to the lung than pressure or parotrauma. So this is an example of the tidal volume. The second loop represents the volume scalar in volume guarantee mode of ventilation, wherein based on the tidal volume reached, the peak pressure of the next breath is changed. So for example, after the second breath, wherein tidal volume was exactly reached, you can see that the same peak pressure was delivered for the next breath. Whereas when the tidal volume dropped below the target volume in the third breath, the PIP for the subsequent breath was increased in the fourth breath. Now, evidence is very much in support of volume-targeted ventilation, wherein it shows that there is a definite reduction in the need for ventilation, risk of pneumothorax, risk of hypocapnia, periventricular leukomalacia, and risk of severe grades of IVH when volume-targeted ventilation is used. And it also culminates in a significant reduction in the combined outcome of death or PPD. Now, once the baby is ready to come out of invasive ventilation, when it comes to post-extubation support, it is believed that the use of non-invasive positive pressure ventilation or non-invasive mechanical ventilation has been found to have some advantage over CPAP as a post-extubation modality because NIMV reduces the need for re-intubation or extubation failure. Although there may not be a significant difference in BPD when we use NIMV in the primary RDS setting or in the primary respiratory distress setting, there is a reduction in BPD also when NIMV is used over CPAP in extremely preterm neonates getting extubated. Now, NIMV might be helping by maintaining the functional residual capacity better because the mean airway pressures are higher and by also improving the ventilation and carbon dioxide elimination by delivering a few positive pressure breaths. Now, elective high-frequency ventilation, although was promising in terms of lung protection by delivering higher mean airway pressures with lesser lung injury, did not actually translate into a net reduction in bronchopulmonary dysplasia from whatever evidence we have. However, in a baby with existing air leak, like pulmonary interstitial emphysema or pneumothorax, it does facilitate in rapid resolution of existing air leak and can be used as a rescue strategy in small babies, such as babies below 28 weeks who require significant mean airway pressures in the interest of reducing or limiting the lung injury. So to summarize, strategies which are found to have proven benefit in reduction in BPD are in terms of ventilator strategies would include volume targeted ventilation and the use of NIMV in the post-extubation setting. Most of the interventions appear to be promising, although they may require more studies to conclusively demonstrate benefits such as the use of permissive hypercapnia strategy, the use of saturation targeting, and other delivery room interventions like the use of TP's resuscitator, delivering gentle positive pressure breaths. Now, probably beneficial strategies include the use of graded FiO2 concentrations for the managing babies in the delivery room, and the use of early CPAP and patient-triggered ventilation, whereas interventions which are found to clearly have no benefit are sustained inflations in the delivery room, and elective use of high-frequency oscillatory ventilation. There may be some role for rescue HFOV, but certainly not for elective or upfront use of prophylactic HFO. Non-ventilatory pharmacological strategies which have been evaluated for BPD prevention include caffeine, fluid restriction, aggressive nutrition, and vitamin A. Now, caffeine is also one of the silver bullets in neonatology, one of the most effective pharmacological agents, one of the most popular pharmacological agents, which came into vogue after the CAP trial published in NEJM 2006, wherein babies born with birth weights less than 1,250 grams were randomized to receive either caffeine or a placebo, and babies who received caffeine were found to have reduction in the risk of BPD, reduction in the risk of hemodynamically significant PDA requiring medical or surgical management, and the combined outcome of death or disability until 18 months, although this particular neurodevelopmental benefit did not persist until 5 years. So what must all of us know as practicing neonatologists? Caffeine can be used at a loading dose of 20 mg per kg and a maintenance dose of 5 to 10 mg per kg per day in less than 32 weeks babies or less than 34 weeks babies, perhaps with apnea of prematurity. Prophylactic use of caffeine less than 1250 grams, although was not strongly advocated by the CAP trial, is a very, very popular strategy that is followed by most units, and also the post-extubation use in very low birth weight neonates getting extubated from mechanical ventilation. And in a post-extubation setting, one would want to continue this until 7 days, whereas in the other two settings, it is usually continued until 34 weeks of post-conceptional age or until 7 days of period free of apneas or free of respiratory support. Fluid restriction is also found to be useful and may be associated with a significant reduction in NEC and PDA and a significant trend towards lesser incidence of BPD. And there is no magic number when it comes to restriction, but most people want to restrict to around 120 to 130 ml per kg per day by the end of the first week. Improving enteral and parenteral nutrition, giving more aggressive enteral nutrition and achieving better postnatal growth undoubtedly is a very common sense based intervention that will be only associated with positive benefits. And it is believed to reduce bronchopulmonary dysplasia. Also, it is said that in babies with established BPD, one may target calorie intake of 140 to 150 kilocalories per kg per day. The use of vitamin A at a dose of 5,000 international units given 3 times a week for 4 weeks was also associated with a significant reduction in BPD, although this has not really translated into practice because of better aggressive nutrition practices. A small word about postnatal steroids in the management of BPD. Now, why do steroids work in BPD? It is possibly because of their anti-inflammatory effect or possibly because of reduction in the pulmonary edema by reducing the pulmonary vascular permeability, and possibly also due to induction of the bronchodilation by upregulating beta-adrenergic activity. So multiple mechanisms are potential reasons for the effect of postnatal steroids on BPD. It results in rapid improvement in the lung compliance and reduction in airway resistance. Now, the efficacy and safety of various steroids have been extensively studied, and it has been seen that the use of hydrocortisone, although moderately, is safer than dexamethasone in terms of neurological outcomes. Efficacy is not very convincing with hydrocortisone. And there are 2 systematic reviews on early and late postnatal steroids, which fairly conclude similarly. Early use of postnatal steroids in the first week of life in preterm infants, although it reduces the incidence of chronic lung disease, is associated with numerous side effects, metabolic side effects like hyperglycemia, hypertension, GI bleeding and perforation, and increase in the risk of abnormal neurological examination, both at discharge as well as later on. Whereas the late use of postnatal steroids after the first week not only achieves a significant reduction in BPD, but possibly does not have most of the safety concerns, particularly the neurological concerns, although this is also associated with metabolic complications as with early postnatal steroid. Now, if we have to use, then what is the course that is to be used? There are multiple recommended courses. I shall not go into the details now. There is also a regimen that advocates prophylactic early hydrocortisone, which came up recently. The Premiloc trial, which looked at a cumulative dose of 8.5 mg per kg of hydrocortisone, which also resulted in improved survival without BPD in babies born less than 28 weeks of gestational age. One meta-regression analysis looked at a case selection of those babies who would rather benefit from postnatal steroid without getting exposed to the harms like increase in neurological complications. So they proposed that when the baseline risk of BPD was more than 65%, those are the babies where steroids would decrease the net risk of death or cerebral palsy. Now, how to identify this group of babies who would benefit from postnatal steroids? One way that has been proposed is to use an online BPD risk calculator. This is now available from the NICHT website in the following link. Although this is widely applicable for the Caucasian race, it includes various variables that we need to enter, such as the postnatal age, gestational age, the birth weight, baby's gender, antenatal steroid utility, whether the baby received versus not, the presence of surgical NEC, if the baby is between postnatal days of 14 to 28, the type of respiratory support, and the FiO2 requirement. So if you enter all these criteria, we end up getting the risk of BPD. Now, the AAP recommendations on postnatal steroid do not advocate the routine use of dexamethasone for prevention of CLD. And wherever it is used, they advocate that there must be full informed consent taken from the family. So this very elegant review that came up almost 16 years ago from the from the All India Institute of Medical Sciences, gave a little pragmatic guideline of where we could think of postnatal steroids. So they do recommend that one could consider postnatal steroid for managing BPD in ELPW babies stuck on ventilator support even after 10 to 14 days of age, after ruling out potential confounding factors like sepsis and PDA, and recommend the use of the lowest possible dose for the shortest possible duration of time. So this is a summary of various pharmacological therapies that we just discussed for the prevention of BPD. Now, it is more difficult to manage BPD fully established. It is rather easier to prevent it. Hence, there is not much to talk in management of BPD. We know that there are three important components: the pulmonary vascular component of BPD, the parenchymal or interstitial component of BPD, and lastly, the airway component of BPD. So how do we manage the fluid overload component? Now, diuretics, which either work at the level of the proximal convoluted tubule, the loop diuretics, such as furosemide, or the thiazide diuretics, may result in short-term improvement in lung mechanics, especially in BPD requiring or dependent on PEEP. But there was no overall benefit in terms of reducing the total number of days on oxygen or respiratory support. And they may be associated with potential harms like hyponatremia and hypokalemia and nephrocalcinosis, particularly with loop diuretics with nephrolithiasis. So there is no hard recommendation for the routine use of diuretics, although we may think of it when there is a ventilator or high PEEP dependent BPD who is not improving even after fluid restriction, and there is some degree of radiological evidence of pulmonary edema, wherein we may choose the safest possible diuretic, such as you may want to choose a thiazide over a furosemide if the baby is at risk of nephrolithiasis, or you may want to choose the shortest possible duration. So managing airway component of BPD is also not that easy. Various nebulized medications, including nebulized bronchodilators or nebulized central anticholinergics like ipratropium, have all been tried, mostly without any possible proven benefits. The one recent study did show that there could be a role of nebulized Budecort given over a long duration of time in the prevention of bronchopulmonary dysplasia. But most studies did not show any significant benefit with the inhaled use of salbutamol, levosalbutamol, or ipratropium. In fact, they may worsen the airway instability because there could be a component of bronchomalacia in BPD. Although attractive drugs like sodium or montelukast, which may inhibit neutrophil activation and chemotaxis, are not associated with any encouraging evidence. So finally, what is the role of tracheostomy in ventilator-dependent BPD? Ongoing acquired subglottic stenosis is one very attractive reason to think of tracheostomy and avoidance of endotracheal intubation. So if there is a baby who is more than 40 to 42 weeks of PMA and who is who has prolonged ventilator dependency, we could consider tracheostomy. One has to remember that this is not something that is associated always necessarily with favorable outcomes, although there could be a reduction in mortality with doing tracheostomy. However, it comes with its own problems. Management of pulmonary vascular hypertension component of BPD has also been tried with various drugs, such as sildenafil, which is a phosphodiesterase 5 inhibitor, which increases the levels of cyclic GMP, or drugs which inhibit phosphodiesterase 3, and with variable effects. So this is a drug which shows the proportion of patients showing hemodynamic improvement with sildenafil therapy. Treatment of acute exacerbations in BPD, such as infections like ventilator-associated pneumonias, wheezing episodes, or episodes of acute pulmonary reactivity and episodes of pulmonary edema, will have to be individualized based on the clinical presentation with various techniques like judicious choice of antibiotics, because X-rays may be misleading, and it is often difficult to differentiate between BPD and pneumonia. So we may have to rely on multiple parameters like blood investigations and other clinical signs, management of wheezing with inhalational medications, and management of pulmonary edema with furosemide and fluid restriction. So these babies also require dedicated follow-up and ongoing monitoring, not only for respiratory problems, but also for blood pressure, because they are at high risk of systemic hypertension. Echocardiographic assessment, usually it is judicious to repeat once at 36 to 37 weeks of PMA, once to look for PAH, and developmental screening prior to discharge. Of course, serial retina examinations for ROP, hearing assessments, etc. The role of RSV prophylaxis with palivizumab or immunoglobulin, specific immunoglobulin, should be considered if there is a child who is less than 2 years, who had severe BPD, who required long duration of supplemental oxygen and diuretic with or without corticosteroid therapy. And this is the dose, 15 milligram per kg, given intramuscularly. This may be considered for a duration of up to 12 months for a baby below 28 weeks, and 29 to 32 weeker might be up to 6 months, but this is not often available easily in our country. So the last 2 slides summarize various pharmacological and ventilator strategies that we have discussed in the early evolving phase as well as established phase of BPD. But to put it in one line, BPD is definitely a condition that we often do not want to treat, but we would rather prevent by lung protective strategies. So thank you all for joining us. And if there are any questions and comments, please feel free to post them either on the Zoom link or on the YouTube link subsequently.
Dr. Aparna garu.
Yes, sir.
I really heartfully congratulate you for your extensive, tough topic, very beautiful presentation, excellent talk, and really you are a moving encyclopedia. Very good slides. And every word is a take-home message, and very useful to all the practitioners, to all the assistant professors, and all the residents. I congratulate you once again. Very beautiful topic, beautiful lecture. And it
Thank
is
you so
a
much.
very big, bizarre, confusing topic. Very beautiful presentation.
Thank you very much, sir. Thank you so much for your nice words, sir. So we will conclude today's session and we'll join you back next Friday with another useful topic. Thank you.